All right, good morning, everyone. My name is Purya Gayumi. I'm one of the current fellows at the Swedish Neuroscience Institute. I'm here to present a case this morning. Our patient is a 71-year-old female with history of L5-S1 laminectomy and in situ fusion that was done in 2012 for her back pain. At that time, the procedure helped her with her symptoms. However, she slowly started developing left lower extremity pain and weakness, which ultimately led to a dense acute foot drop. She was unable to only walk about a block and needed a walker and a wheelchair at that point. And again, these changes were relatively acute in nature. She had done PT and epidural steroid injections in the past. Just a brief overview of her history. She has no major medical problems. She's not a smoker, and her bone mineral density were within normal limits. So on x-rays, as you can see, she has evidence of an L5 spondyloptosis with evidence of degenerative changes. You can see it better on the CT scan here, which I hope it plays. Awesome. So once again, you can see evidence of L5-S1 spondyloptosis and evidence of non-union of a prior in situ fusion, which most likely led to failure and eventually spondyloptosis at this level. And those are the sagittal CT scans. On her MRI, aside from obvious and expected significant stenosis at that level, really no other significant findings. And I'm just going to scroll through that real quick. The axial MRI. And just a very quick overview, obviously, based on the Myerding classification, this would be a grade 5. And the other commonly used classification systems for spondylolisthesis include the Wilts and the Marchetti classification. They're useful to identify the underlying pathology, but they don't really offer much help to guide surgical treatment and prognosis. And therefore, more recently, the Spinal Deformity Study Group, they proposed a classification system specifically for L5-S1 spondylolisthesis and 6 different sagittal postures, and based on the radiographic measurement of the slip grade and the spinopelvic alignment. Just very briefly in terms of how to classify a patient, so you have to you use the degree of slip to determine low versus high grade. Our patient obviously is a high grade. In the low grade patient, PI is used to classify a patient into 3 different subtypes. The type 1, also known as the nutcracker type, which is a low PI, and these patients have a very high load on their L5 pars. And type 3 being the opposite, which is known as also the shear type with a high pelvic incidence. In the high grade, pelvic tilt is then used to determine if the pelvis is retroverted or not, and then balance is determined using a C7 plumb line, and it's considered unbalanced if it falls anterior to the femoral heads. Based on this classification, I do believe our patient is a grade 5. She had a retroverted pelvis, but her overall alignment was balanced. The other advantage of this classification is that it basically groups these patients in an ascending order of severity according to prognosis and a spinopelvic alignment. They also suggest, even though it's still controversial, that reduction techniques might be preferably considered in type 5 and type 6 in an unbalanced sacral pelvis. So treatment options, in the interest of time, I'm just going to go through the possible reported treatment options in literature, obviously in situ posterior fusion, instrumented posterior fusion, anterior posterior circumferential fusion with instrumentation, the Gaines procedure, which is L5 vertebrectomy with reduction of reduction of fusion of L4 to S1, and what this patient ended up having, known as the Bowman technique / the modified Bowman technique. So Bowman's technique is, it's a one-stage posterior procedure. It's a originally it was described as a posterolateral fusion with an oblique inner body, which was an autologous fibular strut. The cons of this procedure is that there's been report of graft site morbidity, obviously. There's been reports of late graft fracture and an incomplete reduction of the listhesis. The modified Bowman, basically describes the addition of transsacral or pedicle screws and uses a titanium mesh gauge instead of the autologous fibular strut, which basically eliminates the morbidities associated with graft. This was published by Dr. Hart in Journal of Neuroscience Spine. The 16 patients with average clinical follow-up of 78 months and radiographic follow-ups of 48. 6 patients had isolated transsacral screws, and 2 of them required revision for non-union. None of the patients that had spanning pedicle screws had any non-union. In terms of nerves, there was only 1 patient that had L5 radiculopathy, but there were no motor involvement at all. And all patients had pretty much improvement of their slip percentage and a slip angle. So in terms of what this patient had, she underwent a posterior spinal fusion, L3 to pelvis with an oblique interbody cage and a long S1 screws into the L5 vertebral body, and these are her post-op images. Her pain subsided dramatically. She still continues to have some motor weakness, but overall she's improved compared to her preoperative state. Thank you very much. Dr. Hart? Yeah. Yeah. Any questions? Or?
Do we have our panel, Lee?
Yeah, you probably have to use this one. You load it up on here? It's on.
I don't see the participants. There we go. There's some austere-looking faces. Dr. Pauly, I know you have some commentary.
Yeah, no, I think the classification scheme, looking at the balanced pelvis, unbalanced pelvis, and balanced and unbalanced spine, is really key to determining how much you have to go after these. And then there's a series of tough choices about what you do. Last one of these that I did, I actually took it down and reduced the spondyloptosis, and I don't know if that's a good idea or not. But when we tried to calculate how much of a PSO would be necessary to correct the sagittal plane, that was not a good answer. And that the other option, which is also a really, really hard operation, is a sacral osteotomy.
Yeah, can you talk a little bit about sacral osteotomy? That's something I have thought a good deal about. I've tried and done some sort of not complete pedicle subtraction osteotomies there, because I really don't know how to get satisfactory distal fixation if you truly did a complete pedicle subtraction of the S1 vertebral body. So what is your approach in doing that? And are there other options for sort of pelvic incidence modifying operations? I know that's
Sure.
part of your talk.
There are reports from Pierre Roussely about doing pelvic osteotomy to change the pelvic incidence. I've not done any of those, and so I cannot comment on them. I know it is an option. That my experience has been really based off of the report out of Northwestern that Steve Andra and Tyler Koski did, and that what I try to do when I do that, they were leaving the patients in 6 weeks of bed rest to let them heal. So 4 big iliac screws, then basically disconnecting the sacral end plate from S1, and then tilting the spine pelvis alignment to get the desired result. The one thing that I would add is that if you can get a through and through iliosacral screw to buttress that end plate, that seems to help a little bit. And where I've had to do this, that there really wasn't an alternative, are the patients who fracture S1 after a long fusion to the sacrum and then are allowed to heal in that bad position. That's a really, there's not really a good alternative to that strategy. And it's just a hard operation, and that you are disconnecting the sacral end plate in whatever way you do that. And then you have to get that angular alignment correct and then lock it into place. And so it's kind of like thinking about it almost like a sacrectomy type of operation in terms of the reconstruction.
Yeah, I agree with those thoughts. I'd say in my hands, I've tended to retreat to an L5 PSO if I need it, and I have not had anyone that I've sent for bilateral Gans osteotomies or some sort of pelvic osteotomy, and I agree that may be possible, but obviously very difficult. And the notion of bed rest for 6 weeks, really in this day and age, is remarkable, but probably necessary. I agree. Ted, do you have a comment?
No, I think my concerns are more with the neuropathy that I have seen when trying to correct these. rather than just accomplish a fusion. So I think we can discuss that at a different time, but that's, I wondered if you've seen any of that.
Yeah, I agree with that comment, and that was one of the things, Dr. Bowman, I will say, I think in his era, and when the year I was with him in 97, I guess, 97, 98, the notion of sagittal alignment was really not part of our mainstream thinking. And so a lot of those patients that he treated were still sagittally imbalanced at the lumbosacral junction. But his argument was that he felt his outcomes were better than the efforts at reduction. And I think we have learned that angular reduction is probably more important than listhesis reduction. And listhesis reduction is really the part that is most associated with foot drop and postoperatively. And this woman actually was just back for her 1-year follow-up, and she had come in with a profound foot drop. And we did correct her a bit in sagittal plane. Obviously, nothing with regard to the listhesis, and I had thought to try to decompress the L5 nerve root and started in that direction, and actually kind of gave up in the operating room because it was just so deeply embedded in bone. And remarkably, I think just from the stabilization, maybe from the elevation of the vertebral body and of L5 off of the front of the sacrum, maybe, but she's recovering her foot drop now. She's not completely resolved, but she has better strength now than she did preoperatively, even without a direct decompression.
Can I make a comment, Bob?
Yeah, you bet.
These are one of the most challenging, these cases are the most challenging in my opinion. These are terribly difficult cases. You know, we all focus on realignment and balance, but at what cost? With osteotomies and reducing listheses. I think this type of particular pathology, get it to heal, get it to fuse with the least amount of complications that you possibly can. And I think patients are they might not be great, but they're good. And I think this is a point where you just don't go for the home run. You go for the double, and you're satisfied with that, to use your Cardinals baseball analogy.
Are you saying the Cardinals are a small ball team? Is that what you're saying?
They win. Doesn't matter.
All right.
It's about winning. It's not about the home run. It's about winning.
I couldn't agree more.
Hello, everyone. I'm Rick Price, and even though I did my training in St. Louis, I'm not a Cardinals fan. Go Reds. So this is a patient of Dr. Hart. This is a 59-year-old female with a progressive history of kyphosis and worsening myelopathy. She has quite a few complaints, and you'll see why here in a second. She has severe neck pain radiating to her left shoulder, bilateral hand numbness, poor dexterity in her hands, low back pain, and numbness in her left leg and foot. On a physical exam, she's motor intact and decreased sensation in the left lower extremity and a Hoffman sign. Looking at her upright plane films, you can see patient has a severe kyphosis resulting in quite a bit of sagittal imbalance, as well as a chin on chest deformity. And she's leaning over towards the left with a little bit of scoliosis in the thoracolumbar spine. Her numbers are to the right. As you can see, just about 15 centimeters of SVA and a 30 degree of pelvic incidence and lumbar lordosis mismatch. This is a cervical MRI showing multi-level cervical stenosis, is most severe at C3 and 4. The question is, how do you treat this patient? There's multiple different ways. The way we did it was in a 3-stage procedure. The first stage, we went after the cervical issues, the deformity, as well as the stenosis, did a corpectomy at C3 and 4 with ACDFs C5 to 7. Then flipped her over to the posterior portion, decompression from 3 to 7, and then a fusion from C2 to T6 with kyphoplasties at T6 and 7. This is postoperative imaging, and you can see a good correction of the chin on chest deformity, and from the CT you can see good decompression of the spinal cord throughout the cervical spine. This is a comparison of the pre-op and post-op images for step 1 or stage 1, looking at the global overall alignment. We let her heal from that operation and brought her back to the operating room for stage 2. This is where we completed the posterior fusion from thoracic, from T6 to pelvis, with additional L4-5 laminectomies and posterior column osteotomies from T7 to L3. These are the postoperative images. You can see nice correction of scoliosis as well as the sagittal imbalance. And then later on that admission, we brought her back for stage 3. And to augment the fusion, we did anterior interbodies at L4-5 and 5-1, as well as a lateral interbody at T10 and 11 to provide anterior column support. Here are the postoperative imaging from there. We used a lateral cage at T10 and 11, and then allograft at 4-5 and 5-1, as well as a quad rod construct from, I think, T11 down to the pelvis. These are the final x-rays. Overall, she's in excellent alignment. SVA corrected to about 6 centimeters, 6.5 centimeters, and a mismatch of 5 degrees. Overall, she did very well. She had an uneventful recovery. Her preoperative neurological symptoms resolved, including the numbness in her left leg. She's now ambulating without assistance and performing all of her activity of daily living on her own. Any questions or comments?
So Dave Polly here. In Minnesota, we've seen a series of these patients essentially fuse C2 to the pelvis. And the thing that we've been most troubled by is when they fall and break their odontoid.
Lee, can we get the faces again? So I hear that comment, David, and I've over the course of my practice, it's still less than 10, but more than 5 patients that I've ended up with fusion C2 to pelvis. Most of them have been patients that all but this lady actually have been patients that I did not start out with that as my initial plan, that had thoracolumbar deformity that then became proximal junctional problems and then ended up with fusions to C2. And out of that cohort of between 5 and 10 patients, as you just alluded to, I've had 2 patients fall and fractured the dens. And I think the inability to look down and watch their feet as they walk really becomes part of the problem, as well as whatever brought them to need these operations in the first place. So obviously it's typically an elderly patient population with some bone density issues. Have you had cases like this where that was your plan from the beginning, was you were going to need to go from C2 to pelvis?
Not really. They've sort of all presented in various stages of either evolution that are the result of my work or someone else's work.
Yeah.
So I can't comment on that.
Yeah, I had never seen that. And one of the questions I have with this patient is, where should our initial distal junction have been? This ended up working out well, but she did develop a distal junctional failure despite using kyphoplasty or vertebroplasty down distally. I haven't used tethers distally, and I'm beginning to wonder whether I should, but I also wonder whether the distal stopping point at, what was it, T6? Yeah, may have been, maybe we should have gone lower. I don't know. Do you have any thoughts on that?
Yeah, no, it's really more how long between the stages, because you knew what you needed to do. And the issue is how do you decide the time interval and staging? And I got to think that probably nutritional parameters and hemoglobin are probably the best measure when she's ready for round 2.
Right, right.
Dave and Bob, I had a question. Kyphosing as we age is a protective mechanism, because we generally want to fall forward and not backwards. Do you think the odontoid fractures occurred falling backwards now that these patients are straight? Or do you think they fell forward? That'd be a very interesting question.
It is an interesting question. I don't have an answer to that. I'm thinking they fall forward, but I don't know. David, do you have any thoughts?
No data, just 1 or 2 memories of people telling me falling forward, but I can't provide data.
Yeah,
I think it's a complex problem. If you try to create consistently a type 2 odontoid fracture in the biomechanical laboratory, it's a lateral blow of the lateral mass to the side of the odontoid. And so if you want to do it in the lab, that's what it takes. And our patients don't talk about falling and hitting the side. So it can be a variety of mechanisms, but that lateral mass smashing into it is part of it. Because something, the ligament doesn't fail, something might be hitting it like that mass.
This is a recent challenging case that one of my partners asked me to help him with. A 60-year-old female. We didn't have a frailty index on her, but she was physiologically probably in 70 to 80 range. She had previous fusion about 10 years before for Scheuermann's kyphosis, and she developed an SI problem that looked like an infection and a L4-5 disc problem that was consistent with infection. Profound sagittal imbalance, needed more work than she could handle at one surgery. And so here are her sagittal parameters, maybe not quite as profound as Bob's case, but similarly challenging. And you can see that she has substantial pelvic retroversion and hip and knee flexion that makes her SVA not seem so bad. But when you look at her T1 pelvic angle at 51 degrees, that's relatively problematic. Here are her imaging studies that show the discitis at L4-5, as well as in the coronal image, you get a sense of her SI joint is not right. And so trying to focus in on her SI joint, there was debate about whether or not this was infection or not, and whether or not she could tolerate the treatment of this alone versus her whole problem. And you see that the 4-5 infection process was probably much more active, at least at this point in time. And so our decision on her was to not do a 3-column osteotomy because we thought that would be more than she could take. Our decision was to use multiple points of pelvic fixation. And so we did our stacked iliac screws, and we used S2AI screws here. And then once we did that, our next step was to address the L4-5 level, where we did an aggressive bilateral T-lift, and that we chose to use a titanium implant rather than PEEK or something else, given the presumed infection. And we did biopsy and cultures, which did subsequently grow out an organism at this level. And then this is the on-the-table correction. And it was not quite as much as we would have liked to dial in her numbers, but we felt that that was what she could handle in one day. We did tie into the existing instrumentation rather than take it out and have to do a further amount of work up higher. And the one comment that I would make is that when we're doing our stacked screws at the bottom, sometimes they line up for a single rod, and sometimes what we try to do is leave the more caudal screw head a little more medial, which tends to allow a little bit easier lining up of the rods. This was the navigation using to clean out the SI joint. And we did, I think I used like a 10 millimeter reamer to drill that out. And then you can see we were able to bone graft that all through the posterior approach. And hopefully that will go on to heal for her. And that we like big screws. And so our standard default screw is a 9.5 90. And I think in her, we were able to put 100 millimeter screws in the caudal part and then 90 in the cephalad part to give us that kind of stable fixation at the pelvis. And that this is what she ended up with as her upright imaging. I would have liked a little more lumbar lordosis, but I think when her Scheuermann's was done 10 years ago, they perhaps overcorrected that a little bit. And so our hope is that this may be enough for her. If not, we'll be back to do the PSO in another day. And I think I've got one more slide. So here are her parameters measured before and after. So we got about 25 degrees of correction through that T-lift at that discitis level, and we markedly improved her pelvic retroversion, and hopefully we've got her in what will be an acceptable, close to age-adjusted sagittal alignment profile.
Well, I think that's a beautiful result, David, and obviously an extremely difficult clinical situation. Can you tell us a little bit about the time frame of what has been your development or migration toward multi-rod constructs, and what have you learned? And I don't want to take away from your talk later, but I think that maybe is outside what you're going to be speaking about.
Sure. So like everybody else, I had the failures of standard 2-rod constructs in PSOs. Then we started using 4-rod constructs. And I liked the concept of the so-called satellite rods. And so that was our first evolution. And then we've had an experience that I'll mention a little bit in the pelvic fixation talk about the set plugs coming out of the S2AI screws. And so that drove us to more robust fixation caudally. And so that we're doing that more often. And then one of the companies makes dual-headed screws. And so we've used a lot of the dual-headed screws to make it easier to put in the 4-rod constructs. And that typically we're using cobalt chrome instrumentation for our rods, in part because I just get frustrated with bending the titanium rods. In a tumor situation or some reason that imaging becomes absolutely critical, then I'll try to go to an more of an all titanium construct. But we've really been fans of we use 5.5 cobalt chrome rods in general, and that if we're going to the pelvis with a long fusion, our default now is more and more to go to a more than 2, whether it's 3 or 4 is a matter of debate, but certainly more than 2 rods.
Right. That's my normal approach now, too. And it's been a migration from initially from PSO, very similar to what you said, initially in PSOs with satellite rods to 3-rod constructs for longer fusion with an outrigger rod, and now a 4-rod construct with 2 outrigger rods. If I haven't done a PSO, that's my typical construct, similar to what you showed here. I have to say, I used cobalt chrome early on, but I was using it in a 635 diameter, and I found it just nearly impossible to bend, and so I went back away from that to 6.0 titanium, and I still prefer that. I also saw a couple of late infections similar to what we used to see around stainless with cobalt chrome, which I just have never seen with titanium, and I think Munish Gupta has done some work that seems to show, without knowing the mechanism maybe, that titanium is more bacteriostatic than either cobalt chrome or stainless. Does any of that ring true for you?
Yeah, so certainly many years ago, we published on the use of titanium cages in acute pyogenic infections where corpectomy was needed. And so I am a fan of titanium in the setting of infection. And it's the number of colony forming units necessary to colonize titanium is higher than for other implants. The difference between stainless steel and titanium and cobalt chrome and titanium, stainless steel gets coated with glycocalyx faster than cobalt chrome, at least is my understanding. And so cobalt chrome is better, but not as good as titanium. And so I would agree with that statement about infection susceptibility.
Yeah. Well, great case. Does anybody else have a further comment? I can't see the other members of the audience just now.
I just have a quick question. It's Andrew Jack here, Dr. Hart. One of the questions that's come up in the chat that I was actually going to ask about with that last case as well is I was wondering if Dr. Pauly or Dr. Hart could talk about the importance of preoperative conversations with the patient with respect to increased stiffness and how this is going to affect the patient's quality of life post-operatively.
Yeah, so Andrew, that's a nice comment. And fusion to the pelvis certainly does change mobility. This scenario, she was so badly off that we improved her mobility, not worsened it. If she had to, self-cath or something like that, that would be more challenging for her to do. and that's probably been the biggest thing for like my paraplegic patients to try to make that work. And so I think differently about a sitter versus a walker. And so a sitter, I will flatten out their lumbar spine more so that they are better able to see their own perineum. And I think that I first learned that from my colleagues in Hong Kong who talked about sitting sagittal alignment versus standing sagittal alignment. And that's been my only guiding thought on that. And then I try to demonstrate in the clinic to the patients the difficulty with trying to be able to reach their feet. And that it really then becomes dependent on how flexible is their hip and how flexible are their knees. But we do have that conversation that this is going to change your ability to put on your shoes and socks. And I also explain the difference in the walking pattern. I call it sort of a waddling pattern because you don't have that axial rotation anymore in the lumbar spine. And so your pelvis turns and your head turns with your pelvis when you're walking. And those have been the biggest things that I've learned from my own patients in retrospect about trying to prospectively inform other patients about expectations of changes.
And I would just underline that. I think I hadn't, so we didn't include the walking change in the lumbar stiffness disability index, but perineal care is one, dressing is one, driving is actually one, looking over your shoulder, and sexual function is, of course, affected. But what we found in prospectively within the ISSG was that these patients, by the time they come for these big operations, most of them are so impacted by their pain that they're really not accessing the lumbar mobility of normal patients. So if you compare the postoperative state of somebody who's got their entire lumbar spine fused to patients with no fusions and normal spines, absolutely these people have disability due to stiffness. But if you compare them to their preoperative state, it really doesn't vary much. So, and I describe it more as it's going to be a nuisance. It's going to change some of the ways they have to do things, but these are things they can still do. They may have to have assistive devices or that kind of thing. But instead of a disability, it's more of a nuisance is the way I describe it to them.
And Bob, I would amplify that. You know, there's a reason why they're having these huge operations, right? I mean, they're so disabled that you know, some of the biggest deltas or changes we see in the pros are in these kind of patients. Even though we are stiffening all people, whether it's C2 to the sacrum or T1 to the sacrum, but you know, if we properly select these patients out and make sure they understand what they're getting into, they can be our most satisfied patients, even though they're stiffer and they have these disabilities that you're mentioning, but they're starting out so challenged and so adversely affected that you know, their outcome scores change are dramatic.
Absolutely, yeah, couldn't agree more. Yeah, shared decision making in this setting is really essential. Yeah.